Hello, everyone. I'm Dr. Elizabeth Claus. I work as a neurosurgeon at Brigham and Women's Hospital in Boston, Massachusetts, within the United States, and also as a professor in the Yale University School of Public Health, which is located in New Haven, Connecticut, in the United States. I'm also the organizer of the International Low-Grade Glioma Registry, and we've been lucky enough to receive funding from your group to collect pilot data for this study. And that pilot data has now been submitted to the National Cancer Institute, and we've recently been awarded a large grant from NCI to further study international low-grade glioma. So to tell you a little bit of background about the registry and what our focus is, the idea is that we know that there are many gaps in terms of understanding the causes as well as the clinical management of glioma, which is the most common malignant brain tumor. And in particular, one form of glioma, low-grade glioma, has really not been focused on at all. Most of glioma research at present has been focused on higher grade glioma, which is frequently defined by the term glioblastoma. And as the American Society of Clinical Oncology and many other international groups note, the precise management of patients with low-grade glioma really remains to be determined. And what I have here, this is a brain MRI picture showing this white area or a low-grade glioma. So a little bit about the International Low-Grade Glioma Registry. We're defining the individuals who would enter the registry as having astrocytoma, mixed glioma, which is also known as oligoastrocytoma. And that term is really not used very frequently now, but it may be noted on some older pathology reports. And then the most common low-grade glioma, oligodendroglioma. The individuals that we're studying are adults because we know that the genetics and characteristics of gliomas in children are a bit different than they are in adults. So our focus is on adults, currently aged 21 to 79 years of age, regardless of when the patient was diagnosed. So the diagnosis may have occurred years earlier. There's no restrictions with respect to sex, gender, race, date of diagnosis, or place of residence. So we do, as you'll see in a minute, have a number of individuals from Europe, including the Netherlands, who have joined the registry. And we're able to do most of the data collection via the internet, so people are able to sign up in that fashion. If we're using the new World Health Organization guidelines, which have really showed the import of knowing molecular markers over grade, we're looking at grade 2 and 3, and also gaining information about chromosome changes or deletions, including loss of 1p, which is a part of the first chromosome, and loss of 19q, which is a portion of the 19th chromosome. And also looking at several other genetic mutations, including one called IDH. So why the registry and why use this method? We've done a lot of different studies in brain and other cancers over the years, and we know that when you're studying a relatively rare disease like low-grade glioma, some of the more traditional means of enrolling individuals, such as using cancer registries, whether that comes from a hospital or a country or a state, generally doesn't include enough patients, unlike if you're studying cancer such as breast cancer or lung cancer. So we decided in this instance to go more directly using social media and patient organizations, such as your organization, to enroll patients and essentially let the patients decide for themselves if they want to register, because traditional means usually you ask the person's healthcare provider if you may approach them. And so that means if the healthcare provider says no, the patient is not even aware that this study is available and that they might enter. So one of the ways that we're able to reach people around the world is to use social media, the internet, and also to work with patient organizations to get the word out. So what are the basic aims? And this doesn't include every aim, but they're sort of the top aims. We want to look at genetics, and that's genetics both in your germline, which would be blood or saliva, and in the tumor, and to see what that tells us about risk factors and how individuals might respond to treatment based upon both their constitutional or germline genes, that's in the blood or saliva, as well as genetic changes that we might see in the tumor. So we're trying to figure out what treatments work best, in what combination, and at what time. And then we also want to look at other areas that are important to patients. Prognosis, genetic counseling, not only for themselves, but family members as needed, family planning, driving, working, and looking at other things which really have not been examined in glioma. So what are the effects of exercise, diet? What's quality of life? What helps with neurocognitive function and outcome? So at present, what are we asking participants to do? We do need consent. We can do this now electronically online. There's an online questionnaire where we ask basic questions about your family history of glioma or any cancers, what sort of treatment you might have had. And then we do try to obtain a saliva or blood sample and a tumor sample. What we are typically doing for individuals that are outside of the United States is we mail a saliva kit to the individual with us paying the postage. We do ask that the participant pay the postage from overseas to the US. And this is what the kit looks like here. You open the kit, give a saliva specimen, put the kit into a plastic bag, and then into a mailer. If you haven't already signed consent, we can send you a consent to sign and then mail it back to us. And we've had pretty good luck with that, getting people from overseas to join us. So at present, we have over 400 patients who have enrolled. The patients are from 21 states and 16 countries, including the Netherlands and a number of other countries you can see listed here. The majority of cases that we have so far are oligodendroglioma, and a good proportion have the 1p19q deletion and are IDH1 positive. And about 20 to 25% of individuals have had a recurrence. So to tell you a little bit about our new grant, NIH, which is the National Institutes of Health, and one of the groups within the National Institutes of Health focuses on cancer, so that's called the National Cancer Institute, has awarded us a large grant, and it's called a Participant Engagement and Cancer Genome Sequencing Research Center. Different centers focus on different diseases, and our focus is on low-grade glioma. There is a website if you want to read more about us as well as the other groups. And if you Google PECGS, you'll come to this website and you can read a little bit more about us and the overall group. So our group has titled our study Optimum, which stands for Optimizing Engagement in Discovery of Molecular Evolution of Low-Grade Glioma. 3 of us are the principal investigators on the study, myself, and I'm based at Yale University and Brigham and Women's Hospital. Bethany Kwan, who was at the University of Colorado, and a gentleman who actually is Dutch, and you, I think, have also supported his work in the past, Dr. Roel Verhaak, who is currently at the Jackson Laboratory, and that's located in Connecticut within the United States. So he will be doing the genetic work for the study. And so what is the goal of this study? So we hope to enroll approximately 500 individuals that are diagnosed with a low-grade glioma and who have had a recurrence. And the idea behind this is that we want to collect tissue from both the first and second surgery in order to see what changes, if any, and this is just a picture listing some of the changes that might occur, but what changes have occurred with treatment. So as you may or may not know, the selection of treatment can be controversial for this group of patients. So we want to look at people that recurred who only had surgery, and also look at people who have had only chemotherapy or only radiation, or the combination of radiation and surgery, and look to see what changes occur. Did we help? Did we not help? And that will help us to decide what treatment to give, what treatments seem to benefit the patient, what treatments seem to not benefit the patient, and what is the best timing. And I do want to highlight Dr. Verhoek's work with the GLASS consortium. GLASS stands for Glioma Longitudinal Analysis. So he has collected some pilot data on mostly higher grade gliomas, as that's a more prevalent group and therefore easier to obtain information on. And so essentially our new grant is basically a combination of GLASS and the International Low-Grade Glioma Registry. And I will say that GLASS and Dr. Verhoek also received some pilot funds from your group as well. So these are some of the questions that we're hoping to answer to see whether or not surgery is helpful, potentially by reducing the number of genetic changes or mutations that we see. We do note that when some individuals receive chemotherapy, it seems to cause more mutations, or something called hypermutation. And therefore, can we identify individuals who seem to have this effect from chemotherapy, in the sense that perhaps we would not give those people certain types of chemotherapy? Another question is when a recurrence is noted. So you get your MRI picture, you see that the tumor seems to have grown. Is it necessary to do surgery at that time? Or can you move to treatment? And does that change with the time in between the first and the second surgery? This should help us develop some therapeutic options for patients with low grade, and to also help us understand how do genetics play into any neurocognitive changes that we see by type or timing of treatment, particularly radiation therapy. So these are the three general goals of the study. The application asked for a component to better engage patients. So that's called the engagement portion. And this is something where even if you are not a person with low-grade glioma, we're actively looking for people to offer input into what the best way is to engage patients and their healthcare providers and their advocates into glioma research. The second component is to actually engage patients and enroll them. As I mentioned, we're looking for 500 individuals that have had low-grade glioma and had a surgical recurrence. And we're trying to learn what is the best way to do that. We have some new tools, one of which is called Hugo, and that is how we will be registering people online. And then something called archetype mobility, which is an effort to try and offer clinical trial information to patients in a more digestible fashion. And then Dr. Verhoek will run the genetic testing. We will do testing on both the germline, which will be blood or saliva, and both tumor samples. So that's the tumor from the first and the second surgery. And then we're going to try to deliver genetic reports back to study participants. And we're trying to learn more about what the best way to do that is. What is a way that patients will understand and be able to use this information and be able to incorporate it into their clinical care. So these are the goals of the new grant, to try and better engage patients into our study, and so that we have a more diverse a group of individuals, so that we're representing people from across different races, ethnicity, both males and females, and people from different socioeconomic background. We know that's important because people from different socioeconomic background may be exposed to different environmental factors, and those factors may have a role in defining risk. So I'll talk a little bit more about the two tools that we are using. And I just want to present this so that if any of you do decide you're interested in joining the registry, you'll have seen this before. So essentially, it's an online cloud-based platform in which patients allow us to obtain their medical records electronically. It also it's based a little bit more in the United States, but we do have some ability to obtain information from overseas. It is hooked up to different healthcare systems, pharmacies, different payers. The payers are only within the United States, but also wearables, right? So that can be anywhere in the world. And so what we're looking to collect eventually by connecting to people's wearables, and all of this is done with the patient permission, and you can pick what parts you want to hook up with. We're hoping to look at activity, exercise, and movement in terms of outcomes for low-grade glioma. So it will also be our registration. Consent will be online through YouGo. And any sort of questionnaires that we have, we're hoping to have probably a questionnaire every year, including in the future looking at people's occupation, their activity, their diet. And then we hope to present dashboards and information back to patients, both at an individual level and to keep people posted about our studies and other studies that are involved in the brain tumor community, as well as in glioma. And eventually, we hope to not only use our research portion of this platform, but to develop what we call a kindred or community or group of low-grade glioma patients who may or may not be in the registry. Some people may just want information and not feel comfortable joining the registry. Other people may want to do both. And so be looking for that as well. And then our second software, called Archetype, is to take the information from clinicaltrials.gov, which actually includes clinical trial information from around the world. It is not just US based. And to use artificial intelligence to create an app and a program that would make it easier for glioma patients to find trials that they might be eligible for and that they could bring to their healthcare provider to see what might be best for them. So we're going to identify, engage, and enroll participants. YouGo will do the registration, consent, and questionnaires. We do realize that some people may or may not have appropriate internet, or their hospital may not be large enough to allow for the hospital portal to be entered. So we realize that we will have to assist people via internet. We can do it via Zoom, and we can try to help patients to collect their pathology for those instances in which they're not able to hook up to YouGo. We'll send the specimens to Jackson Laboratory, where the genotyping will be done. And then we plan to return reports to participants and providers as the participant wishes. So as I mentioned, in addition to looking at treatment and the role of genetics in terms of risk, outcome, and response to treatment, we eventually hope to look at exercise, activity, and diet, and also to look at chemical exposures that might be measurable either in the tumor or in the blood. So we did recently find in a very small pilot study an association in glioma tumors with a chemical called haloalkanes. And interestingly, this is a very common chemical in flame retardants, And those flame retardants can be on your clothing, your furniture, and obviously individuals that are firefighters might have very high exposure. So we have received pilot funding to look at genetics of glioma in a small group of firefighters within the San Francisco area. And as I'm sure you've seen on the news, because in California there are many fires associated with the weather and the climate, these are individuals that have had high exposure to flame retardants. So we're going to be looking to see if we can find a closer association between glioma and these haloalkanes. And we hope to do similar sorts of things in our optimum and registry study. So that is a quick survey of some of the things that we're interested in. If you are looking for more information, we would be happy to give more information out. You can contact us at glioma@yale.edu. You can scan this in. If you go to International Low-Grade Glioma Registry on the internet, you can go to the NCI website or any of the groups that sponsored us, in addition to your group, the American Brain Tumor Association, the National Brain Tumor Society, and the International Brain Tumor Association were all kind enough to help us to start our study. And so we do want to end by saying thank you so much. I won't attempt to say your group's name in Dutch, but we do appreciate the funds that you helped us to collect pilot data with. And then we were able to turn that pilot data into a very large grant. Actually, we received almost $13 million from the National Cancer Institute. So you can see that your funds went to good use and really did help us to move on to something larger. So we hope that you'll keep us in your thoughts. Please join us in whatever fashion is comfortable for you. If you would like to just be on our email list and hear about things we're doing, send a note to glioma@yale.edu and we will do that. If you want to join the Register Optimum, you can also do that. We would love to have you. And we're on Twitter at Glioma Registry. Facebook, we have not been that active on Facebook, but we're setting up a whole new Facebook group now that we have new funds, and we're going to be developing a new website. So join us at glioma@yale.edu, and we'll keep you posted on everything that we're doing. And again, thank you so much to your group. And I hope that you enjoy your meeting.